Hello, good morning. I'm Dr. Sridhar. Welcome. I'm doing a quick live session as YouTube is encouraging us to do more live sessions, and now they have the vertical live streaming for those of you who watch on your phone as well. So, today I was thinking of covering a very important topic. It's something that is used every day in the neonatal intensive care unit, but we don't put too much thought into it. At least the doctors don't think too much about it. So I'm speaking about the feeding tube, the nasogastric or orogastric tube that we use. So obviously it's very important to have it. For the first point, that we want to decompress the stomach if the baby is on non-invasive ventilation, which is the commonest route of ventilation these days, preferable. And the second point is most of these babies are unwell to suck feeds, so we give them the orogastric or nasogastric feeds. Uh, there are two benefits of it. One is that there is no risk of aspiration if the tube is in the right place, and we can control the volume more specifically, because if the baby is directly breastfeeding, we don't know if there is a risk of choking, and also if the baby is on oxygen support, the desaturation and other issues can happen. So this helps us to maintain the nutrition even in the relatively sick babies. When it comes to feeding tubes, we have the two routes, the orogastric route and the nasogastric route. Obviously, in older children and adults who are not ventilated, the nasogastric is a preferred route. The orogastric, it's an irritant. We are more sensitive to anything going through the mouth. And because it moves when we move our mouth, it can cause discomfort with gag at the back of the throat. The nasogastric is more secure because the nasal passage is long from the front to the back. It kind of fixes itself there, and because it doesn't move as much in the back of the throat with our regular movements, it's fairly stable, probably more comfortable. But when it comes to newborn babies receiving non-invasive ventilation, it's obviously difficult to use nasogastric tubes because the non-invasive ventilation is through the nostrils. So we have either the ram cannula or the high flow prongs or the CPAP prongs and mask. All these fit over the nose, and we depend on that. And actually, to improve the efficacy of non-invasive ventilation, we use chin straps or position the mouth in such a way that the baby isn't keeping the mouth open, so the pressures delivered are maintained. So the orogastric tube is probably the only option in a baby on non-invasive ventilation. In the initial 1 or 2 days in a very small baby, they may need invasive ventilation with the ET tube, and the ET tube goes through the mouth. So in most of the situations, some units use a nasal intubation for the same reason, it's more stable, but it needs a little more technical expertise, and most units use a oral intubation route. So the nose is available, but even those cases, I prefer not to use an nasogastric tube, partly because we are going to extubate at the earliest. Nowadays, we tend to extubate early. We want to keep as much of non-invasive ventilation as possible. And secondly, when we put the nasogastric tube, when we extubate the baby, we are going to need non-invasive ventilation in majority of such cases. So if the nose becomes edematous, the nasal passage is edematous, then it makes your non-invasive ventilation less efficacious. So it's important that we maintain the patency of the nose using saline drops, even when the baby is intubated, and we don't use vigorous suction for the same reason, because if you put a suction catheter through the nose, you are going to traumatize, and the resulting swelling narrows down the already narrow passages. And what happens when we extubate these babies and we need non-invasive ventilation? We need the nose open, and when the suction catheter or the feeding tube doesn't go through, we use a little more force that causes more trauma. So it becomes a vicious cycle. This is particularly the case in the extreme premature babies, where the nasal passage gets clogged very easily. You may get blood stained secretions, and sometimes we use topical treatment to reduce the swelling, which is not ideal, but we need it. So in these cases, it's very important we teach our nursing team to maintain the nasal patency, adequate humidification of the gases that go through the nose, avoiding trauma by regular suctioning, keeping the nose patent. One is by the humidity, by keeping the prongs at a comfortable level, not too tight and not causing pain, because pain also causes inflammation and swelling. And secondly, and using saline drops, just dripping in, not to suction, but drip it in so that it goes to the back of the throat and keeps the nostril patent. So this is about the nose patency and why we may prefer the orogastric tube even in babies with an endotracheal tube. The second point about the oronasogastric tubes is how they are fixed. So we don't want the baby to be pulling it out. So you don't need to reinsert, because inserting it's not difficult, but at the same time there is a risk of trauma. Baby may resist it, and it's not pleasant. Obviously, you can use sucrose before the insertion to relieve the pain, or the mother can hold or cuddle the baby. So the securing, preferably use two levels of fixing. So one at the mouth or nose level and one on the side of the cheek, and then coil it around. So if there is a pull, it pulls at the first tape on the cheeks rather than pulling it from the mouth and displacing. And if you start seeing secretions called loose, you can put agadam or something duoderm which sticks nicely to the skin despite wetness. The third important point is about where it is placed. So the confirmation on X-ray. Ideally, when we do the X-ray for babies with respiratory distress, we should have the feeding tube in place, because all these babies need to decompress the stomach. So the feeding tube has to be in place, and when we do the X-ray, we can see if it is high or low. Slightly deeper feeding tube is more acceptable than a high feeding tube, especially if we start feeding these babies, because a high feeding tube which stops short the end of the foot pipe or just at the top end of the stomach has a high chance of reflux, and also aspiration, because these babies are supine, and when we feed, the milk may find its way up if it's not in the stomach. So this gastric sphincter may be closed, esophagogastric sphincter, and the milk may come and get aspirated. So many babies have microaspiration with reflux, and that is one of the reasons why babies who are on feeds get desaturations frequently, especially when they go up on the feed volume. So I prefer to use 2 hourly feed volume to reduce the actual amount of stomach contents. The more bloated the stomach, either with gas or with the milk volume, the higher the chance of reflux. So there are 2 techniques. I have a video on which level to position the feeding tube on the X-ray, and we can either use a standard measurement, which is till the xiphoid and then add 1 or 2 centimeters, or the more commonly used one where we come to the from the nose or the mouth to the ear, and then down to the midpoint of the umbilicus and the xiphoid. So this is probably likely to result in less short placement of tubes. So I would prefer the latter technique. So I will share the link to this particular video in the video info. So the position where it is taped, we always note down which number is there, and at each feed and each shift change, they should be checked. If it slips, we have to make sure it's reinserted and secured properly. The baby grows over the first few weeks. So if it's a long stay in the NICU, we need to make sure that the measurement is repeated as the baby grows, and the feeding tube is adjusted accordingly. And this is not a routine issue because it's for the long stay babies, but the senior nurses, experienced nurses always do that. Whenever we do an X-ray, make sure you look at the feeding tube position as well. We want it in the midpoint of the stomach, but it can be a little deeper. A deeper feeding tube may find its way past the pyloric sphincter into the duodenum, and in those cases, we get greenish aspirates many times. As greenish aspirates may indicate feed intolerance, many times we end up holding the feeds. So the first step to do if you get greenish aspirates, baby may be stable or it may be a sick baby, but in either case, we end up holding feed. So it's very important to make sure that the feeding tube was not deep in the first place. So you go back to the first X-ray, so measure again to see if there is a room to pull back the feeding tube by say 1 or 1.5 centimeters. And many times this clears the greenish aspirate unless the baby is really unwell and it's like a reverse peristalsis happening because the gut is not moving well. In most of these situations, the uh, feeds are stopped and we need to work up for factors which cause the gut to be sluggish. But where the feeding tube was deep and you pull back, it's a simple thing that resolves the problem and you can resume the feeding again without worrying. The high feeding tube, obviously, sometimes the tube slips back when you do the X-ray, so it's always safer to remeasure and fix it in the right place. We don't necessarily need a repeat X-ray, but always look at the depth of insertion, make sure it's consistent with what you measure, so we don't miss any issues in that. So I don't know how many of you are watching right now, but we can stop this. And if you have any questions or comments, we can review that in the comments as well. Thank you.